I wanted to thank everyone for joining today's webinar. I would like to present you Dr. Rosa Romero. She's from the Pediatric Kidney Transplant team in the Virgen del Rocío University Hospital in Seville. Dr. Romero, thank you for joining us today.
Thank you. Thank you.
I give you the floor.
Okay. May I start now?
Please go ahead.
Okay. Good afternoon, everyone. Thank you for inviting us. I am talking on behalf of the Pediatric Kidney Transplant team in our hospital. We are a large team, and as all pediatric kidney transplant teams are. And here is one of the recent pictures from last year. Without many more introductions, I am a pediatric urologist, and the focus I want to give to this webinar is about surgery itself. I have no conflict of interests. I would like to start with a case. So we were referred this 3.5 years old girl with a past medical history of being born at term without any prenatal diagnosis. At birth, she was found to have hydrocephalus, an urogenital sinus, and no information on renal function could be gathered at the time she came to a clinic. However, she had a GFR of around 24. So these are the images from the neonatal and early in her life studies that were performed at the local hospital, where we can see that she has a small bladder with a genital tract, 2 vaginas here, and some sort of contrast coming up, probably one of the ectopic kidneys. And the ultrasound scan that she was done around 1 week of age, she demonstrated a horseshoe kidney like in the left side and a very dysplastic kidney also in the right side. She was performed an MRI that showed this picture of a kidney mass like a horseshoe. When she arrived to us, with this past medical history, she was done at her local hospital a vesicostomy and a virginostomy, and she was having urinary tract infections, but otherwise she was fine. She had low weight, but she has a mild moderate developmental delay. On ultrasound, she had dilatation of the left-sided horseshoe kidney. And we did an endoscopy that demonstrated this urogenital sinus, this common channel with the bladder and the genital tract, an absent bladder neck. This sinus was very short, and we couldn't find any ureteric orifices. And she also had a vaginal duplication. We performed surgery on her. We did a urogenital sinus mobilization, pulling that sinus to the perineum so she could have an urethral orifice and a vaginal orifice, and we did a bilateral ureteric implantation. We found those to be in her vagina, and we closed her vesicostomy and her vaginostomy. 6 months after that surgery, her bladder dynamics were adequate with a bladder capacity of 91, and compliance that wasn't that right, 10, but the transfer pressures weren't high, as you can see in this trace. She had vesicoureteral reflux, and she couldn't void. We started her on CIC from the beginning, and we continued her after this study, anticholinergics and bowel management, as she was very severely constipated. Her kidney function further deteriorated with time, although she was quite stable for quite some time. She had a polyuric renal disease. And at the time, we did an ultrasound scan to check for her abdominal vessels, and we found this to be an issue. As we can see here, there's only an arterial structure here, and there's no aorta-like type vessel, and she had a very abnormal IVC2. We tried to do an interventional radiology study, but we couldn't progress any of the catheters to get a contrast that could be of value to plan for her renal treatment for her kidney transplant. With all the images from the CT scan, we then went to our 3D print lab, and we could manage to get this print and assess the vessels for a suitable place for her anastomosis for the kidney graft. A few months down the line, she underwent a kidney transplant. She was on hemodialysis at the time. She was 8 years, and she received a deceased donor graft, a left kidney, from an 11-year-old boy. And the access was planned to be transperitoneal, as we had planned a very high anastomosis in this abnormal artery vessel in her abdomen. So this small video shows how at the end of this anastomosis, the artery was grafted to the artery vessel here, and the vein that can be here to the remnant of the IVC that we found on our 3D study. Her creatinine dropped very nicely, and she's still doing quite well. 1 year down the line, her graft is looking well. Her bladder looks good as well, although we haven't done an invasive study, and her DMSA scan is looking good too. So from this case, I would like to have a further presentation of a little experience, very modest experience that we have with patients with lower urinary tract anomalies, and I would say more pelvic anomalies and vascular anomalies, as we can see in this one patient that is one of our case series. How many of those patients do we have? Very, very few. End-stage renal disease, fortunately, is a common, uncommon disease, and in the last 10 years, 152 patients were transplanted in our unit. 43 of them had anatomic cacut, and 8 had anatomical vascular anomalies. Only 5 of these series had both pelvic or urinary tract anomalies and vascular anomalies. And I would like to describe these series a bit further to discuss with you what we have done. We have had these 5 cases. All of them had abnormal urinary tract with complex ectopic ureters outside the bladder. Also, 3 of them had a form of horseshoe kidney, but only 2 had a high imperforate anus or high cloaca. They also had some other pelvic malformations, such as dysplastic Mullerian remnants, absent bladder, absent neck, Mullerian or Mullerian agenesis. The vascular anatomy was not that significant in the first case, as she only had an anomaly of the left iliac vein that didn't affect transplant, but all the others had significant anomalies that we would describe further, and that changed the way or the way that we plan surgery or we plan transplantation for them. So what did we do from the urological management point of view? Diagnosis was made upon an imaging with ultrasound scan and MRI. We had functional assessment of the lower urinary tracts with videodynamics, and all of them had endoscopy in the aim to find where the ureteric orifices were. The aim of the treatment was to maintain a urinary tract integrity as much as possible, avoid stomas, maximize residual renal function, and preserve bladder function. We did a vascular assessment aiming to plan for transplant and to see if transplant was feasible. As we can see in this case, some of them looked very, very abnormal, But anyway, the first test that we did was Doppler ultrasound scan. When abnormal, then we proceed on to do a late phase contrast enhanced CT, and in some selected cases, interventional radiology. Once we have this imaging, we proceed to our 3D print lab, as we do with some other vascular anomalies. And with this imaging, we, together with the engineers there, we do the segmentation, and then we do a 3D imaging optimization in order to go from this very messy image where everything is in the field and we couldn't probably work on that, to an image that can be printed and that can assist us in diagnosing and planning. So in this case, that is one of our cases in this series, we can see that there's a very abnormal looking like IVC or abdominal vein. These are the two abnormal kidneys, dysplastic and very small, and she had a supramesenteric aortic bifurcation with a vessel that goes towards the abdominal, to the anterior part of the abdomen. This process here that we do along with the engineers allows us to differentiate what is what, because in some cases where anatomy is unclear, we need the assistance of radiologists and some other professionals too. We have a 3D simulation research study, and for training in kidney transplant, we do use this very same lab, and then we can print from previous models, patients that have had studies because of other reasons, kidney grafts, and we can have this model of the bony structure of the patient, of the recipient, and we have learned that having the liver is a very good idea to plan for surgery and obviously the main vessels. So in that particular case that we were describing in the 3D printing process, we can see how finally the transplant was done. We can see that this here is the artery, and here all the bowel is placed to the front of the patient, and we can see how this vein is anastomosed to this area of this abnormal-like IVC. So what were the clinical outcomes of these little case series? We have very short experience in the last 3 cases, as they were all transplanted 3 months ago, but so far their outcome has been good. For the oldest cases, they have maintained a very good graft function, and we didn't have any intraoperative complications. Operative time was similar to other transplants, same age, same size of the patient. What we have had is a different approach, as we planned in advance to do transperitoneal in 2 of the cases where the artery, the aortic bifurcation was inframesenteric. So regarding the urinary tract, one of the patients has a stoma because she has no bladder. She has an absent bladder, and her native urinary tract is diverse to a stoma of one of the Mullerian remnants that she's got and is functioning, but all the others are on CIC with or without anticholinergics. On the outcomes that we have, a longer outcome, the first case, she's having recurrent UTIs despite good management, but all the others so far have been good. So if we take into account that incidence of end-stage renal disease has dropped from 2008 in Europe and in Spain, But we have to take into consideration that small patients is in incidence of kidney transplant and end-stage renal disease has increased. However, we know that these anomalies are very rare. So I would like to go in depth into what this is or what this could be. So in the last decade, CACUT has been the term considered for congenital abnormalities of the urinary tract and kidney, and we can divide those into anatomical and non-anatomical. CACUT per se is a complex and entails a complex spectrum of anomalies with diverse severity, and that is disease-specific, that has a disease-specific management. What we like to, in this case of patients, in this series, we need to study those that have lower urinary tract anomalies. And why is that? Because this can have an impact on the outcome of the kidney transplant and should be planned and managed from the very beginning. So why, lower urinary tract anomalies can be really very diverse too. It includes a complex spectrum of anomalies from congenital to acquired, that also have a disease-specific management, and that if untreated, like this, the girl with a 10-year-old sacrogenesis that was transplanted 3 years ago and had this ultrasound scan on the left with a very good-looking graft on the ultrasound scan. After a few months of no treatment compliance, she has a very dilated graft, and these are the urodynamics of this girl. So lower urinary tract anomalies, when affecting the lower urinary tract function, can affect in the long term the kidney graft, as it did with the native kidneys and upper urinary tract. We try to identify the high-risk bladder. And what is a high-risk bladder looking like? It's a bladder that has a low compliance, that has increased bladder pressures and filling, which impair the drainage of the ureters, and also that has high pressures on voiding or emptying, and mainly when it is associated with urinary tract infections and vesiculational reflux. But what is a safe bladder? A safe bladder definition is an adequate bladder capacity. We use these two standards for bladder capacity if they are below 2 years of age or over 2 years of age, although this has been based on nomograms that sometimes do not accurately represent population. We require low filling pressures and as good as possible compliance. And we say that a compliance above 10 mils is good enough. We also would like to have low voiding pressures, although voiding pressures in childhood, normality has not been stated. So we know that voiding pressures in boys can be as high as 66 centimeters of water and 57 centimeters of water in girls. We have added here that effective bladder emptying is something required to say that a bladder is safe. And regarding the vesiculational reflux, there are hundreds of papers that we can read in favor or against treating reflux. But we know that vesiculational reflux associated with urinary tract infection can impair kidney function. However, evidence is scarce, is very low quality. There's unclear definitions on what is safe or what is unsafe, and there's a high variation on the management. This is one of the available management plans for patients with end-stage renal disease and bladder dysfunction or lower urinary tract dysfunction that tries to advise on what to do depending on if the patient has a bladder that is able to improve or not. What do? We do try to assess the function of the lower urinary tract as good as possible. We use the clinical assessment, of course. Ultrasound scan as kidneys and ultrasound scan of the bladder can give us information on how the bladder is behaving and urodynamics. And we try to be as less invasive as possible, starting with the less complex, moving up to the more complex. And we are always committed to conservative management. And we check if this conservative management, one started, what effect has it in the lower urinary tract? Is it improving the bladder function or is it not? Conservative management classically is based on anticholinergics, CIC, and bowel management if the patient has a spina bifida or any other forms of neurogenic bladder dysfunction. And we try to implement in our minds that less is more most of the times. And why is that? Because we have unclear definitions on how what is a bad bladder or a good bladder. And there's also uncertain outcomes. And also there's a limited interpretation of urodynamic studies in these patients, especially if they have oligoanuria, polyuria, or has been the subject of many surgeries and bladder is not functioning or is dry. There are two options. Urinary diversion is less popular and is only used in areas where surgical care is not available, and it has an uncertain effect on pre-transplant renal function and very high morbidity sometimes. Augmentation cystoplasty is the gold standard surgical care for bladders that are high risk because it allows a bigger bladder with a good capacity, but it entails chronic intermittent catheterization. And we have to take into consideration that the function of the bladder may change after kidney transplant, especially in those patients that have polyuria, and that it has high morbidity and long-term consequences. So it should be delayed as much as possible if we consider that to be safe for the kidney graft. When do we plan for bladder reconstruction? We do pre-transplant if it's high risk and is clinically indicated to improve the situation of the patient awaiting for kidney transplant. We all know that from the time a patient is listed for transplant or has a significant renal function impairment, sometimes it's a long time before they actually get the kidney. We know that it's an irreversible hostile bladder and has a preserved diuresis without polyuria. After kidney transplant, in those patients that had anuria, polyuria, or has a high risk of urinary tract dysfunction despite adequate management post-transplant, we tend to wait around 6 months minimum to take the decision to do a bladder augment. So our aim in deciding for surgery is to preserve any residual renal function in pre-transplant patient, preserve urinary tract integrity, and minimize morbidity, avoiding any unnecessary conservative or surgical treatment. And we always ask ourselves, or I think we should ask ourselves, can our treatment improve these patients' outcome pre-transplant? Can our treatment improve our patients' outcome after transplantation? And we have to prepare the bladder and the patient because these treatments are very demanding and the patient needs to be involved as well as the family. And we have to also note that we have to prepare the patient to receive more than a kidney transplant in a lifetime. But what happens with those patients when they get treatment, they have a lower urinary tract anomaly that causes their renal end-stage disease? Survival is comparable to other diagnoses, although they are at increased risk of pyelonephritis and urinary tract infection. And what happens, same as here, when the survival is divided into lower urinary tract and other anatomical causes of a CACUT, survival is comparable. But all these papers say or state that they have to have an adequate management of the lower urinary tract function. And I want to say that I'm very critical about this because as this paper here, the evidence behind this advice is low. It's based only on retrospective papers. Results are analyzed over a long period of time. There's no systematic set of outcomes and many factors such as vesicular reflux are not systematically analyzed. And so far, we don't have a standard urodynamic values of what is normal and what is not normal in children. And what happens if we add anorectal malformation? Well, anorectal malformation patients requiring a kidney transplant are going to be mainly cloacas and very high anorectal malformation, and they are at higher risk of graft deterioration as per these two series of patients. And what happens about the vascular anomalies? Well, vascular anomalies are of unknown incidence. We know that there are some congenital, as we have seen in this series, but they are mainly acquired. They are relatively frequent where central lines are used in the IVC, and we don't know, but there are some reports about patients having a previous kidney transplant. What is the available evidence? In a literature review, there's only 3 series that study long-term of IVC and venous anomalies. There's only 1 series of aortic and IVC anomalies, and all the others are case reports. And what we can extract from this is that sometimes these patients are rejected from some teams, some transplant teams. There's even a proposed classification to assess for the risk of kidney transplantation in these patients. We have a small, modest series of vascular anomalies in which we have assisted our transplantation with 3D printing, and from what we can advise from the literature is that graft selection may be helpful, avoiding large grafts from big adults, especially if the recipient is below 20 kilos. A detailed vascular assessment is advisable with angiotac, phlebography, 3D printing, and even there are some cases that surgical exploration has been reported as part of the assessment. And in these discussions, I can say that I have more questions than answers, but probably patients with complex lower urinary tract anomalies, especially if associated with anorectal malformation, may have an increased risk of congenital vascular anomalies. They are extremely rare. I haven't found any evidence in the literature of such an association, and interdisciplinary and multidisciplinary approach is required. Thank you.